Hello everyone and welcome back to Family Matters. This is part 2 of an interview I've had with UK doctor, Dr Dermot Kearney, and particularly around his experiences around prescribing the abortion reversal pill and what happened to him in the United Kingdom. As I say, this is part 2. You can always jump on to the likes of YouTube to get the first part and get the whole interview together. So look, enjoy this second part of the interview. The key point I'm wanting people to understand is, again, that doctors prescribe pharmaceuticals all the time that are off-label. I've always remembered there's one, I think it's called Avastin. Long and short for listeners, as my understanding, it's used quite a lot now in ophthalmological areas, but it initially started urologically. So how it got from one end of the body to the other, I don't understand in this country, but it was doctors who were using it, probably off-label, and it's developed from there, as you've just said. So talk about the evidence. You've talked obviously about babies saved. You've looked at the clinical trials. What if anything are opponents of your and other doctors' work pointing to? What is the supposed evidence of the harm that this has caused?
Yeah, there is. First of all, there isn't any evidence whatsoever of any harm. So anyone who says that it's harmful, could be harmful, is speculating, and they're fabricating or trying to fabricate something that doesn't exist. So there's probably the best way to look on it is abortion pill reversal is a two-stage process. Just as the abortion pills themselves is a two-stage process where you take mifepristone to basically kill the baby, so it causes detachment of the developing the developing placenta from the lining of the womb. So it causes detachment, interferes with the process of the development of the placenta. So basically starves the baby of nutrients and oxygen and blood supply, and then the baby will die. And then 1 or 2 days later, misoprostol, which is a powerful prostaglandin analog, causes uterine contractions and expels the baby from the womb, plus the baby and the developing baby at either the embryonic or fetal stage of development, plus the other products of conception, so the developing placenta and other tissues. So it's a two-stage process to induce an abortion by chemical means. Similarly, abortion pill reversal is a two-stage process. The very first stage is the woman decides, I'm not going to take misoprostol. So she's already taken mifepristone, the progesterone antagonist or receptor antagonist. So she's taken that, but she's decided, I'm not going to take misoprostol. Now, if she takes both abortion pills, there's a 98 to 99% chance that her baby will die. So there's less than 2% chance her baby will survive if she takes both, as she will have been instructed to do by the abortion providers. Not all of the abortions will be complete, mind you, and some of them, about 7%, will subsequently need to have a second procedure, a surgical procedure, to remove the incomplete abortion, but the baby will be dead in 98 to 99%. A small number will still survive. The majority of those who do survive that two-pill stage will end up being aborted surgically anyway. But there are many cases of babies who have survived both abortion pills. If she takes the first abortion pill, mifepristone, but decides not to take the second abortion pill for some reason, either it's not available, or she forgot to take it, or she's deciding, no, I've changed my mind, I want to save my baby. But if she doesn't get progesterone, but she has taken the first pill but not second, there's about a 20% chance at best that her baby will survive. Now, it depends to a large extent on the stage of gestation. If it's past 11, 12, 13 weeks, there's a better than 20% chance. If it's less than 10, 11 weeks, there's a less than 20% chance. But overall, about a 20% chance at best that her baby will survive, as long as she doesn't take that second pill. If she takes progesterone, so she's taken the first pill, decides not to take the second pill, but is given progesterone in sufficient quantities and promptly enough, we can more than double that survival rate. So we can reduce the certain death rate of 80%, if she doesn't get progesterone, to less than 50%. So about 40, in my own experience, about 45%. So our success rate is about 55%, in terms of reversing the effect of the mifepristone. So that's remarkable. There are very, very few interventions in medicine where you have a condition where there's a certain mortality rate of 80%, where you can, with a simple intervention, reduce that certain mortality to less than 50%. So it's more than doubling the survival rate. So survival rate from 20% up to 55% is reducing the mortality, certain mortality, not just possible mortality, certain mortality from 80% down to 45%.
So is there...
It's defibrillation and sort of emergency resuscitation where success rates are quite good in the hospital setting. So somebody has a cardiac arrest in a hospital setting, there's a very good chance that they will be resuscitated successfully. They may not survive long enough to leave hospital because depending on what the underlying condition is, but at least they will have an initial resuscitation. And that is all down to defibrillation, basically, recognizing the rhythm problem on a heart monitor, coronary care monitoring setting, and delivering the emergency treatment as quickly as possible. So that's a definite, someone who's definitely going to die, and by defibrillating them, you can nearly always save their life, at least initially, although they may die from subsequent other complications. In the out of hospital cardiac arrest situation, we get very excited that we have defibrillators on golf courses and pubs and cinemas and supermarkets and shopping malls, in the hope that if someone has a cardiac arrest, we might be able to save them. And the out of hospital success rate is maybe 10-15%. We can save a small number of people. So reducing a certain mortality of 100% down to maybe 85% by this measure. So we get very excited that we're reducing a relative mortality by 10, 15, 20%. Whereas here we're reducing a relative mortality by a simple natural treatment that is very safe to well beyond that. So there are the people the pioneers of this, I feel, should be nominated for a Nobel Prize, because this is really groundbreaking, life-saving stuff. And I'm sure that there would be even greater demand for it if women knew about it, and if they weren't being lied to and told, oh, it's dangerous, or don't go near that, it doesn't work, it's dangerous, it's quack medicine or things like that. So getting back to the danger, so they've come up with this idea. First of all, the initial complaint was, oh, there's no need for this. Women don't change their mind. And we know that was the initial complaint, because before danger was ever mentioned, I mentioned that I came across these articles and online things where people were opposed to abortion pill reversal. And the main name at that time was Daniel Grossman in California. There's a very telling interview on Huffington Post, actually, which again isn't a pro-life publication, I think. Where he's interviewed by a journalist who says, so Dr. Grossman, so what is your real concern about this abortion, the so-called abortion pill reversal? Is it that the drug is dangerous? No. It's nothing to do with the drug. It's the rhetoric. It's the rhetoric that women change their mind, and we don't know that we know that women don't change their mind. And I think the reason he was trying to emphasize that was that if he and his co-workers and pro-abortionists and abortion providers accepted that women change their mind, they would then have to ask, well, how many women change their mind? And I suspect it could be at least 10%, maybe 20%, maybe more. But I think at least 10% would change their mind if they could, and if there wasn't coercion, and if they were given enough support, even after they've taken that first abortion pill. Because if you accept that women change their mind, then there's a very, very uncomfortable question to be addressed, and that is, why do women change their mind? And we know, certainly in the UK, and I'm sure it's the same in New Zealand and Australia and the United States, women change their mind because they change their mind because they're not giving, or they would change their mind because they're not giving the truth to begin with. They're not told exactly what abortion is. They're not told that you don't have to do this. There are helps out there. We can provide material help, psychological help, emotional help, family help, and whatever help you need, we can help you to get through this, educational help. So that help isn't there. They're just given no other option. We know from the Irish situation, there's a thing called the Options Helpline, where women are directed to this Options Helpline. They're only given one option, that is abortion. They're not told, well, actually, there's a pro-life organization in your life, or there's a pregnancy crisis center in your area that might be able to help you. None of them are ever told this by any of the abortion providers. So that's the first thing, that they tried to say that women don't change their mind, but then it became pretty clear that women do change their mind. So by the abortion pill was only available in the United States from around, I think, 2000, whereas it had In the UK, it was available from 1990, so we had 10 years of experience of it, but knew nothing about abortion pill reversal until 2014 or so. So already by 2012, women were changing their mind in the United States. They set up the program. The first year or two, they had a few hundred cases, but as I said, now they've got 5,500 successful cases. Now, for every success, there's going to be another, maybe one, or for every one or two successes, there's going to be another failure. So you can take that at least 8,000, 9,000, maybe 10,000 women have changed their mind in the United States alone over the last 12 years. So we know that women change their mind. There's no doubt about that. The second thing is they tried to say, well, it doesn't work. And they tried to show that it was ineffective. They tried to prove that it didn't work. And they called it quack science or pseudoscience or quack medicine and so on. And one of the main proponents of this was a colleague of Daniel Grossman called Dr Kearney from the University of California in the northern part of California. And he was quite outspoken, and eventually, though, he realized I've read this online, the statements that he made. Eventually, he said, I'm going to have to prove that this is quack medicine, that it doesn't work. So I'm going to have to design a trial, because they had no evidence that it didn't work. And in the meantime, George Delgado and others, particularly George Delgado, had published a paper in 2018 showing that abortion pill reversal was, and the series that they published, although I have a few little problems with it, but they published up to 68% success rate with oral micronized progesterone given promptly to women who had taken mifepristone. Now, there were a few caveats to that. It was an observational study. It wasn't a randomized controlled trial. It was looking at case reports from lots of different places, mainly in the United States or from other places around the world, and gathering them all together. But they found a 68% success rate in babies who had been born. The mother had taken mifepristone but received oral progesterone. Surprisingly, those who had received vaginal progesterone, because you think that might be more successful, had a less than 50% success rate, but still much more than the 20% success rate that you might get with just not taking the abortion pill reversal. So there was evidence starting to accrue that this was successful. So Mr. Kearney decided he was going to have to set up a trial. And in 2019, 2020, it was published in 2020. So throughout 2019, they decided they were going to design a trial that would prove once and for all that APR was ineffective. There was, again, no mention of danger at any stage, because they knew that this was just progesterone. Progesterone is used in obstetrics and has been for decades. So they didn't expect there was going to be any danger. And that was never on the cards. But they wanted to show that it didn't really work compared to placebo. Now, in our minds, because of the information we have available, we felt that a placebo-controlled trial at this stage would be unethical, because we saw what was happening. It would be the same as in resuscitation context. If you decided, well, defibrillation seems to be working, but we can't really be sure, maybe we should do some sort of dummy trial and set up some dummy service. So that would be totally unethical when you see what's happening. However, they decided they would do this. Now, again, an important thing to realize here is a good scientist does not design a trial trying to prove something. They go in with an open mind. They've got an open question. I wonder, does this work? I wonder what would happen if this happens. Because he decided, no, I'm going to prove this once and for all. So he went in, obviously, with a biased aim right from the start. So when he designed a trial, they took a number of women, mothers who were pregnant, who were scheduled to have surgical abortions anyway. They were going to have an abortion at a certain stage, but they asked them would they mind delaying their abortion for 15 days, just over 2 weeks, to allow them to do this trial to show us to see if this drug worked or not. And they were going to give all of them mifepristone, and then they were going to give half of them progesterone 24 hours later, into the same protocol that George Delgado and colleagues had recommended, and they were going to give the other half placebo, and they wouldn't know. There would be a double-blind trial, so neither the patient nor the doctors participating in the trial would know which drugs the cohort were getting, the clients were getting. Now, they decided they would only need 40. They were going to give 20 in each group. Now, that, again, suggests this was a trial designed to show failure, because I can't think of any drug where you're trying to compare one drug against another or one intervention against another, where you would only have 40 patients, because to get a statistically significant difference, most of the trials that we use in mainstream medicine will have thousands of patients, and you have to have them properly matched. So you have to have roughly the same age. Obviously, there were only going to be women. There was only going to be no men in this, I hope. So it was a female trial for mothers who were pregnant, but there could be a wide discrepancy of age. There could be a very wide discrepancy of obstetric history, which is actually, I think, very important. And I've noticed that from my own women who've had multiple previous miscarriages are less likely to have a successful outcome, even by giving them mifepristone, by giving them progesterone after mifepristone. Other medical conditions that they might have, other medications that they might have, educational status, socioeconomic status, the weight, the height, the BMI of the individuals, all of these things have to be properly matched so that you've got equal type of person in each group before you can say, yes, this is the reason why this treatment failed or why it succeeded compared to the other one. And there was no effort made to have a proper matching of the two groups. So they just took 20 women in each group. And also, that type of trial, there's always going to be a dropout rate. And in something as controversial as abortion, where women are a bit anxious or nervous and they want to just get on with it, there's always going to be at least 10% dropout. So they had recruited, so they started their recruiting. They managed to recruit 6 into each group. 6, they all had received mifepristone, 6 received progesterone, 6 received placebo. 2 dropped out. 1 in each group dropped out within 1 or 2 days just because they didn't want to take part anymore without any specific reason. That left 5 in each group. And at the end of the 15 days, those 5, 4 in the progesterone group were still pregnant. 2 in the placebo group were still pregnant. Surprisingly, I'm surprised that there was still 40%, but 2 out of 5 were still pregnant. That was obviously a cause of concern. To me, it was obviously a cause of concern for the authors, because this was not supposed to happen. This was a trial study, in inverted commas, designed to show that this treatment didn't work. And now, even at a very preliminary stage, it was already showing signs that it's working somehow. So they noticed that 2 women in the placebo group had significant hemorrhage. 2 of them had to attend the ER. They were told that if you have severe bleeding, because every woman with mifepristone is going to bleed, there's always going to be bleeding, unless they get progesterone, which can stop the bleeding or ameliorate it. So 2 of the women in the placebo group had bleeding. 1 of them required a blood transfusion, so she obviously had a heavy bleed, and the other woman required an urgent surgical abortion to quell the bleed, stem the bleeding. 1 woman in the progesterone group had a lesser bleed. She had a bleed. She attended the ER department, but they checked her out. They checked her hemoglobin. It hadn't dropped. It was within the normal range, and she didn't require any emergency intervention. She didn't require a blood transfusion, and she was sent home. So at that stage, there was 10 women, 5 in the progesterone, 5 in the placebo. 4 out of 5 were still pregnant in the progesterone group, 2 out of 5 still pregnant. So that was a double survival rate, which is exactly what my figures have been shown, and what the George Delgado figures have been. It was consistent with those results. There was a minor bleed in the progesterone group. There was a possibly more serious bleed in the placebo group. So placebo didn't do anything to stop the bleeding. So they stopped the trial. They stopped the trial on the basis that 25% of the people involved had serious hemorrhage, and therefore it was an unsafe protocol, and this could not be allowed to continue. So they put out this message that while the statistically significant, they couldn't make any sort of conclusive declarations or findings from the study, that it raised concern that women undergoing abortion pill reversal, there may be a danger of excessive bleeding. Now that's one way of looking at it, but they didn't emphasize that the only women who had significant bleeding were those who didn't receive progesterone. You could argue, and the theory is that misoprostol, the second drug, the abortion second drug that causes uterine contraction, that by causing muscular contraction, it might actually constrict blood vessels, prevent bleeding, or at least limit the size of bleeding. But again, that's speculation, because we know that many women who have taken both abortion pills and have successful abortions will end up requiring blood transfusions. So it's certainly not a safe thing to do. Mifepristone is what causes the bleeding, but misoprostol, while it expels the baby, which is almost always dead by that stage, it doesn't necessarily, or there isn't any evidence to say that it definitely stops the bleeding. So I think a very valid way of looking at that trial is that it was stopped on the basis that the authors did not like what was happening. So they had to come up with some explanation. So they come up with this thing that, oh, it's dangerous, abortion pill reverse. Now, there's no evidence whatsoever that progesterone is dangerous. As I said, it's been around for 50, 60 years. If they say progesterone is dangerous, they're going to have to stop using it for prevention of miscarriage. They're going to have to stop using it in IVF. And that's going to hit a lot of private practice throughout the developed world, and a lot of these people who thrive on their IVF industry. So they can't really say that that progesterone itself is dangerous. So they come up with abortion pill reversal using progesterone is dangerous. But there's absolutely no evidence to support that. And I would be happy to debate that.
Well, that's one of the things that it seems to me, as I've looked at the New Zealand context, there's lots of footnoting for the position statement that no one's to advertise or sell progesterone as an abortion reversal. Again, I'm a layman, but as I've read the material, there is no substantial data. And I suppose what I'm long and short getting to is it strikes me as incredibly ideological. There seems to be a very particular view of the moral rightness of abortion, and therefore anything that challenges it has to be done away with. And even some of our prestigious colleges here are saying it's unethical. It's not safe. And they're welcome to say that, but I've not seen any evidence of it. And so it sounds like this is the same experience that you've gone through where you are.
Yeah, well, we have to. And this basically they're telling lies, because there is no evidence now. They're being fooled, they're being led to believe, and for some reason they're naive and they're accepting the statement from the people most opposed to this, that the extreme sort of pro-abortion people are opposed to APR. So the other colleges are accepting this, or at least the leadership of the colleges. I certainly in the UK they have never polled their members. And similarly in the United States, they had never polled the members of the American College of Obstetricians, because I think they would be afraid to, because as I mentioned, our expert witness who does perform abortions, he was very happy to accept that there was nothing wrong. He wasn't entirely convinced that there was a lot of evidence to support its use, but he said that there is some evidence there, and it's obviously very safe. So there was nothing wrong, and there was nothing wrong with a cardiologist, a general physician prescribing progesterone, which any family doctor should be able to prescribe in the right context, as long as they know what they're doing, and they're prepared to follow up on patients and report any adverse effects that might be found. And similarly, when eventually the GMC got their expert witness involved, it took them a long time to find one, but eventually they got one. And again, he or she, I won't mention what sex the person was, but came out quite strongly in favor of what we were doing, and had no problems with the actual services. So the only concern that he or she was about was that there was a question of money, because one of the accusations against me was that I was accused of paying for the treatment for some of the women, that I was obviously putting them under pressure. Now that was true actually to some extent. It was because some of the girls couldn't afford to pay for the treatment. Now the treatment was not expensive, because I always got them 2 weeks treatment at a time, because I didn't want them spending a lot of money on something that may not work. So we went 2 weeks. If that was successful, which I've just done yesterday, and we have a young girl who's just starting the process, and she's doing fine, and I sent her another prescription, so she's going to do another 2 weeks treatment, and then that'll get her close up to 12 weeks. So once we get to 12 weeks, then we can stop treatment usually. If they're already over 12 weeks, I just give them 2 weeks of treatment, because by that stage the placenta is producing enough progesterone that we don't need to continue for long periods into the second trimester. We need to get them to the second trimester if we can. So some of the girls, all of the girls, I had to explain to them that this was not a normal NHS prescription. Unfortunately, it has to be paid for. I don't charge anything, but the pharmacist will have to be paid for the drugs. And the natural question that they all ask is, well, how much does it cost? And I'd say, well, in my experience, in most places around the country, it's between 20 and 25 pound for a 2 week supply. And they said, fine, that's okay, I can manage that. Some didn't, though. Some didn't have the money. Said, I'm really sorry, I don't get paid till next week or till 2 weeks time. And I would then ask them, well, if that's the only reason, if you really want to go ahead with this treatment, I've explained all of the potential pitfalls and side effects and the chance of success, the chance of failure. If you really want to go ahead, and if the only thing stopping you is not being able to afford it, I will help you to pay for the drugs. And I would do that. And I did that on a few occasions. And so the expert witness from the GMC side was a bit concerned. He thought this sounded almost like a bribery type thing. But we were able to point out that we weren't actually paying the woman, we were paying the pharmacy. In fact, initially, the first couple of times I tried to do it, I tried to actually directly pay the pharmacy, but the pharmacists, they won't accept money or a credit card from an outsider. It had to come from the client. So I then had to arrange somehow to put money into their account that they would then give to the pharmacist. That was how it worked. And once we explained that, then the general medical counsel expert witness was happy. So he or she had absolutely no problems with the service itself. It was just this concern over were we bribing these women to do what we wanted them to do.
So just to be clear then, obviously there's the ethical considerations, and I could see why that would be a question. But ultimately, you mentioned just quickly in the side effects, and before we wrap up, you've talked about the clinical trial, and obviously, well, bit of a sham, really, says me. But are there other side effects that are potentially possible because of the use of progesterone in this case, including, if I might add, sort of a psychological impact of someone's wanting to reverse their earlier decision to abort using I've got to look at my notes, I can never say it right, but mifepristone. Is there a risk that they feel if they take progesterone that they think this is going to solve it, and therefore if it doesn't, that it leads to a further harm? I mean, where are the attack points from the other side on the clinical, if you will, psychological side, or is there none?
There's none. In fact, it's exactly the opposite. When any of the mothers have contacted myself or Dr. Riley or any of the other providers, and I'm sure this is the same all around the world, certainly in our experience, any of the mothers who've contacted us and have been given progesterone, they are so grateful, and that even in the cases where it didn't work, they are so relieved that they tried, that they didn't live with this guilt that I've killed my baby. At least they tried to do what they could, knowing that there was limitations to what they could do. Obviously, in the cases where the treatment has been successful and the babies have survived and they've got healthy, happy babies when they're born, they are so grateful. And actually, their whole families are very grateful. And initially, I never thought of the fathers of the babies. I never thought of the extended families. It was only when I got to meet some of them that I realized there's other people involved here too. We got to meet 4 or 5 of the fathers as well as the mothers. There's a picture that's been going around on social media that was taken, Christian Concerner. After we won our case, they arranged a little photo shoot with mothers and fathers who were welcome to come along if they were able to do so. And I got to meet the fathers for the first time, which was wonderful. So the psychological impact that it has on the mother is tremendous, and in all cases. And I mentioned that we got 10 witness statements from the women. As I said, we could have got 40. We chose 10 because we wanted to get 10 different stories. We got 2 or 3 from women who'd had their babies and were so grateful, and they gave glowing accounts. I was in tears because I wasn't allowed to see the witness statements or to be involved. It was done through the legal process. So I just had to ask the girl, would they be happy for me to give their contact details to a lawyer so that they could discuss the issue. I wasn't allowed to have any involvement. But when I read some of the things that the girls were saying about the service, I was in tears I didn't realize the depth of gratitude that they had. So we got some from women who'd had the babies. We got some women who were pregnant and were due to have the babies but hadn't delivered yet, but they were so grateful. We got some from women who had tried the treatment and it hadn't worked, and they were still very grateful. One woman said it restored her faith in mankind, that somebody could be so generous and so caring that to try and help her in her desperate hour, our darkest hour. We even got 2 statements from women who decided not to try the treatment, because some of the women, about 35% of them, after they've contacted me, because they all came to me, I didn't go looking for them. I would explain the likelihood of success, the likelihood of not being successful, side effects of progesterone, which is basically nausea, maybe tiredness, and some occasionally headache. So there are some side effects with the drug, especially for the first 3 days, because we give a high dose 3 days, then a lower dose for subsequent weeks. So I had to explain all these things, and some of the women decided, for whatever reason, usually again because of coercion. Some said, I'd really love to, but my boyfriend says he's going to leave me if I don't have this abortion. Or in one case, one poor girl said, my boyfriend's going to commit suicide if I don't have the abortion. So that sounds to me like emotional blackmail to an extreme extent, but that's what we were up against. So, and we had to respect that. We never tried to force it, because there was no point. If we tried to force it, the girl would just resisted it. So we offered it. They came to us, we offered it, we explained to them, and if they wanted to go ahead, then we were very happy to try and help them and support them all the way. So we got these statements from women, and they were all so grateful, including those who decided not to go ahead. Some of them rang me up afterwards who decided to go ahead with the abortion. And they rang me up 1 or 2 days later to say, I really wish I had followed your advice and gone ahead with the progesterone, but I've made my decision and I can't go back on it now. Some of them I've referred to. There's a wonderful organisation called Rachel's Vineyard that I've asked them if they need any help, and some of them they've gone to their own family doctors and have helped. Some of them have, a small number have gone to Rachel's Vineyard and have been very grateful for the emotional additional support that they've received through other women in situations like themselves. So to answer the question of is there any psychological impact? Yes, very much so, but all very favourable. There is not a single negative psychological impact that I've come across or that has been reported.
And nothing developmentally, I'm again just trying to tie off loose ends here, nothing developmentally for the children that are born, there's no effects there that have been noted?
Yeah, that was the most important thing for me, that before I got involved, as I said, I took 6 years before, so 2014 to taking it a little bit more seriously, 2018, then eventually 2020 getting involved. That was my big concern, is that. So I waited, I observed, I waited till enough cases were coming through from the United States until the children were 1, 2, 3 years of age to make sure that once I was happy that there was no developmental, there was no increased risk of congenital problems. And even that is one thing that the abortion providers are happy to agree on. The mifepristone providers, the mifepristone manufacturers, they will tell it. And there have been lots of studies done on this, looking at, even before abortion pill reversal, studies were being done looking at the impact on the baby if the baby survives. And there wasn't that many, but there were some. And there was one particular study done in France, Bernard et al., where they followed the babies, and even some of them who'd survived following both abortion pills, but those who'd also survived with the mifepristone, and they found there was no increased risk of congenital problems for the children. So mifepristone, and I tell that to the mothers, and some of them will ask me, is there any danger that it'll damage my baby? And if they don't ask me, I insist that they do, because I never finish that conversation or prescribe progesterone until we have covered that issue. It's very important that they know that if the baby survives, there isn't any increased risk of congenital problems. That mifepristone either kills the baby outright or it doesn't have any long-term effects at all. The effects wear off usually within 10 to 15 days. So if they can get to 15 days without miscarriage, whatever happens thereafter will not be because of the mifepristone. Some will probably have natural miscarriage, which happens up in maybe at least 10% of all early pregnancies anyway. So that was going to happen even with progesterone occasionally. We've had a few late miscarriages that are really hard to take, but the mother at least knows that she has tried her best. She has undone the harm that the mifepristone might have caused, and this was just God's will, or whatever way they want to look on it. That it was an inevitable thing that was going to happen one way or another, despite the support that they've got. There was nothing more that they could have done. It doesn't happen very often. Usually if they get to 15 weeks, the vast majority, I think I've only lost one baby who died naturally. There was a couple more were forced into abortions by other people, even after the 15-week stage. But of those who had naturally lost a baby, I'm only aware of one once they get over the 15-week mark. So it's the early second trimester.
Well, look, thank you for covering all of that off so thoroughly. As I say, I think there's a lot of mischief at play, for want of a better word, down here, and I say that because, again, there's just a lack of evidence. There's a lot of statements, but as I keep saying, when you delve in behind the statements and the footnotes, it's like, okay, well, where are the trials and the inputs? So, Dr. Kearney, thank you so much for talking us through not only the, if you will, the practical side of what this is and what is happening, but also through your quite remarkable experience. So, again, thank you for providing us context down here in the Antipodes from your direct and immediate experience there in the United Kingdom.
Can I just say one final point, because I think this is important. I saw you had a wonderful interview recently, I think, with Dr. Callum Miller, one of my colleagues here in Callum and myself are probably the two most outspoken pro-life doctors in the UK. There are others, but we're probably the two, certainly on social media. But Callum and myself, and also in the US, people from APLOG, the American Association of Pro-Life Obstetricians, Christina Francis in particular, Donna Harrison, we have many times, we have challenged those who oppose abortion pill reversal just to a live, open public debate. We're very happy to just have an honest public debate, but all of our advances in this area, all of the requests that we have made have been turned down. They will not debate us in public because they know that these truths will come out, and that any accusation they can put down, whether about not working or dangers or quack medicine or anything they have that they throw at abortion pill reversal, we will be able to answer, because we have the evidence, we have and we have truth on our side. But so far, maybe as a result of this, somebody might be brave enough to debate myself, Dr. Miller, Dr. Francis, Dr. Harrison, or others involved in providing the service. I'm often accused of being the one and only person doing this, but I'm one of about 1,500 doctors that I'm aware of. I know in the United States there's well over 1,200, 1,300. There's not many of us in the UK, just a small number have been doing it. We've got 62 babies so far. We have another at least 4 on the way, maybe more that I'm not aware of, but at least 64. But compared to the US with the 5,500 over 12 years, we're still at very early stages. But for the mothers involved and for the fathers involved, it's such a life-changing experience for them. So we would welcome public debate, and I hope that maybe in New Zealand, Australia, those countries down there where there is fierce opposition to it, I hope that the people who are leading the opposition will be brave enough to publicly debate and just seek for honest answers, rather than sort of making a statement without any evidence and then running away from it without being prepared to defend the statement in public.
Well, I think that's part of the problem down here, is these sort of statements, granted coming from our Ministry of Health, so it's not coming directly from the clinicians actually, but that aside, it's an attempt to have a chilling effect, because they're basically trying to silence debate and discussion around this at all. So again, incredibly grateful, Dr. Kearney, that you've taken the time to come on and chat with us, and we wish you well with your continuing practice.
Thank you very much. It's been wonderful. Thank you.